So we've all been in this position, I'm sure, at some point in time, and if you haven't, you'll get there eventually, because you do enough cases and bad things will happen. So, here are my disclosures. Okay, so what's the definition of sudden hemodynamic collapse? It's a previously stable patient who develops a life-threatening blood pressure, rhythm, and/or respiratory compromise during PCI. But is it really sudden? Complications should always be thought of, right? Every time we're doing a case, we should be thinking about all the things that can go wrong so that we prepare ourselves. And preparedness is key. Now, oftentimes, I have my fellows set up the table as neatly as possible so that when something bad happens, they're just ready to go. And that includes having 20 cc syringes filled with normal saline with no air in there, so if God forbid there's an air bubble that goes down the artery, they're ready to go to power flush with normal saline while the nurses are getting the medications together. So that's what I mean with preparedness. So what's the challenge? The challenge is that when something goes wrong, it could be a number of reasons, and you don't have much time really to figure all of that out. We can't really multitask. Okay, what we think is multitasking is rapid task switching. It's very inefficient. Your mind cannot be on two places at one time. You're just going back and forth, back and forth. The other challenges are that not only will you react, but your entire team reacts. And you need to figure out how to coordinate your reaction and your team's reaction. So the way I look at it first is, are the changes real? Is the blood pressure real? Is the rhythm real? So here's a case of a 62-year-old man with an NSTEMI who did radial access. The blood pressure at baseline by cuff was 140/90. After access, but before we took a picture, so before contrast was given, we just brought the catheter up to the ascending aorta, hooked up, and we see that the invasive blood pressure is 70/40. So the first question is it really 70/40? Check on the patient, see how he or she looks, look at the EKG, see if there's any ST changes, any rhythm changes, check the pressure gauge level, just make sure that's in line with the patient, V0, check the pressure gauge for air, sometimes there's an air bubble stuck in there during the prep. And then you can also check the catheter, especially if you've had some trouble manipulating the catheter for a little bit, because sometimes what you can end up having is a kink in the catheter. And some of the things that we'll try is, first, obviously, we'll try to untwist it under fluoroscopy. You can try to pass a stiff body J wire, but sometimes it will be a really tough kink. And then what I've had to do with more stubborn twists is to cut the hub of the catheter and bring a long sheath all the way up to the kink to be able to pull for leverage. So if the changes are real, if it's not an iatrogenic issue, then the next question is, can the patient perfuse, oxygenate, and ventilate without support for 60 seconds? If the answer is yes, then you have time to think. You go through your differential, you go through your reversible causes, and keep going through, and then you act. So what are some of the differentials? Sort of think about it in terms of pre-PCI and during PCI. So the first thing that goes through my mind is bleeding. Is there any access-related issue? Ischemia. If you think an air embolism has air has gotten in, so say you haven't cannulated an artery and the catheter is in the aorta, the most likely place the air will go is through the RCA. So we once had a case in the middle of the night. The nurse was flushing the pressure gauge from the back end. She hadn't communicated with the operator. So the operator was still working, not knowing that the nurse was trying to flush the pressure gauge from the back end of the table. There must have been an air bubble. We hadn't even taken a picture and the patient started going south. And the question was, if it's air, where would it have gone? It most likely went down the RCA rather than the LCA. So you try to cannulate that first. And then for air, I recommend having power flushes of saline while you're getting medications to support the patient. If it's a large embolus, I've been able to manually aspirate it out. You look at rhythm, you can have tachyarrhythmias. You can also have vagal reactions. I know when we were doing more femoral, years ago, vagal reactions were very common. But we do still see it with radial access. So we do, most of our cases now are radial access, but we still have a vagal syndrome now and then. And it's important to remember that you can get that with radial access as well, or heart block. Then you think about cardiac reserve, mechanical complications of an acute MI, contrast reaction, medications that may have been given, and then finally breathing, pulmonary edema, airway obstruction, or over-sedation. Now for the medications, particularly if you're giving radial access, you want to think about what's in your cocktail. So I usually use verapamil in my cocktail. I think it's much more potent than nitroglycerin. But I will not use it in critical AS patients or EFs of less than 20% because at that point the patient has very little reserve. You think the cardiac index is very low, they have very little reserve and they'll take a long time to reverse. And so I'll switch out verapamil for nitroglycerin in those patients. Okay, here's the case of a 70-year-old woman with diabetes who comes in with substernal chest pain and abdominal pain for an hour. She's in distress, she's uncomfortable, but she's hemodynamically stable. Her EKG shows Q waves in the anterior leads and some ST elevations. She's brought up to the lab. Here's her LAD. You can see there's a severe lesion in the mid-LAD after the bifurcation, but there's essentially TIMI-3 flow. Left main and circa okay. Here's the RCA, mild to moderate disease in the proximal segment. But again, TIMI-3 flow. She starts worsening on the table. She starts writhing around now. She can't sit still. She seems in even more acute distress, and her blood pressure is now 70s over 40s. We do an LV gram. When you're not sure what's going on, do an LV gram. So we do an LV gram, and she's got a VSD. So essentially, she had TIMI-3 flow because she had recanalized her acute MI. What she was presenting with was an acute rupture of the ventricle. So here you can see flow from the LV to the RV. She went to the OR immediately and ended up walking out of the hospital a week later. Okay, so during PCI, I have a few other things in my differential. Not only do you look at axis-related bleeding, but you can also think of perforations in the coronaries. And adding to the ischemia differential, not only can you think about air emboli, but you've got atheromatous air emboli. This is your classic slow flow, no reflow. We were talking about this yesterday in terms of how you can potentially deal with slow flow, no reflow. And in addition to all of the things that we talk about, nitropeside, adenosine, if a patient's hypotensive, I see epinephrine can work. And so we'll just take a 1 to 1,000 dilution of your code dose, what you give during ACLS protocol, and instead give that intracoronary. And it does tend to work pretty well in a hypotensive situation. A dissection is a possibility, thrombosis, check your ACT. Also, the equipment that we're giving can interrupt flow with the vessel. If there's extreme tortuosity, you can have bleeding, so just bring your wire back to restore some flow. Or collateral interruption with microcatheters. And then finally, there's also guide catheter dampening, so you want to sometimes just readjust the guide, or keep the wire and balloon down the artery and bring your guide out into the aorta to make sure that the pressure is real. So this is a case of a 58-year-old man, CAD, prior stents in the RCA and the LAD, diabetic, hypertensive, comes in with chest pain, found to have an NSTEMI. He has a severely calcified Prox RCA lesion, and IV intravascular lithotripsy is performed. Once that's performed, there's some difficulty in removing the balloon, but eventually the balloon comes out and you're left with this picture. So if you don't see it already, there's some blossoming here. I think what happened was that the wire was down this artery, and when they were trying to remove the IVL balloon, the wire was bouncing back and forth. And eventually they wired down the right AV groove, but here's a wire perforation. They delivered coils here pretty quickly and embolized the perforation, or stopped bleeding that way, finished the procedure. Okay, this is a case of a 56-year-old woman, active smoker who comes in with chest pain, found to have an NSTEMI, you get radial access. The RCA is diseased. Some of this distally is spasm, and some of it's relieved with nitroglycerin, but there's still a residual lesion left behind. So physiology-guided PCI was performed, and the distal RCA was ballooned with a 2O compliant And this is a picture after the balloon inflation. So trying to figure out what's happened here, right? An acute occlusion. Now the patient's not doing so well. So first we did a long inflation with the balloon just to temporarily restore flow in case it was a dissection flap or even if it was a thrombus. But as soon as the balloon was removed, there was a recurrent occlusion consistent with the flow limiting dissection. So luckily, at this point in time, I looked at the fellow and I said, don't move the wire. If that wire moves, you're dead. Luckily, the wire was still in place, and so we were able to stent safely from distal to proximal with IVUS guidance. This is the case of a 71-year-old man who comes in with exertional angina on medical therapy. His blood pressure and heart rate start off pretty well. Echo shows a mildly reduced ejection fraction with apical hypokinesis, and we get radial access. So here you can see in the caudal view there looks like a severe lesion. Sorry, doctor. But in the cranial view, it doesn't look terrible. So we do an FFR. And the FFR is significant at 0.65 with IV adenosine. Now in this case, we had used the old assist catheter, which is a microcatheter, a catheter that's used to check the pressure gradients. And we had some difficulty in bringing that pressure catheter back. And there was some calcium on the angiogram, so we made a decision to perform rotational atherectomy. So during atherectomy, a 1.5 burr, patient develops chest pain with ST elevations, becomes hypotensive, requires boluses of neo, 0.5 of atropine, and we take this picture and you can see pretty slow flow in the circumflex, occlusion in the LED. So unclear what's happening. We throw a second wire in the circumflex, we inflate the LED with the 1.5 balloon just to restore flow. And simultaneously, because I'm on the radial artery axis, my partner scrubs in and gets right femoral artery axis under ultrasound guidance and throws in a balloon pump. And this was really helpful to be able to just move out the arm and continue working on the coronaries while my partner was putting in the balloon pump so that we were limiting the amount of time needed to rescue this patient's anatomy. So with flow restoration, chest pain, blood pressure, and ST segments normalize, but you can see there are these lucent filling defects from the proximal LAD through the diagonal, suggestive of a thrombus. Maybe there's an underlying dissection. We check ACT, we're using bivalirudin at this time, so ACT was 385, we're happy with that.
Abdullah.
Unclear what the etiology still was. We did put in a drug-eluting stent with the idea that this was probably a dissection. You can see that the thrombus has moved distally here. So we do manual thrombectomy of the distal D1, and there's still some residual thrombus all the way down at the end, but stores pretty much restored in the main vessel and some of the other branches. And at this point in time, the patient was stable. We watched him a little bit more closely in the cath lab before removing the balloon pump and perfusing the artery. And then the last case is a 68-year-old man who comes in with exertional dyspnea and throat discomfort on medical therapy. Again, blood pressure 64, heart rate 64, blood pressure is just a little elevated. Has a positive stress test and a normal LV function. This is LAD. So normally when someone says exertional dyspnea, I don't think much of it in terms of angina unless I'm seeing, Timmy tube flow here, which is what we're seeing in an LAD. The RCA was non-dominant. The left main and circumflex had mild disease, so a decision was made to perform PCI of the LAD via radial access. So the balloon crossed relatively easily and was pre-dilated with a 2.0 compliant balloon, and then taken with a 2.0 NC balloon up to 24 atmospheres. But you can see here that it's dog-boned and it hasn't really expanded. So there was a lot of calcium there that just wasn't about to yield. So we performed rotational atherectomy with the 1.5 balloon, and now we have no flow in the mid-LAD. But the distal vessel is still filling via collateral, so we had a feeling that this may be a dissection rather than slow flow. patient's not feeling very well, so now that we've at least drilled, we're able to go back in with an NC balloon, and the balloons are starting to expand well. And just with inflations of the balloons, you can see restoration of flow. So based on IVUS, there was a dissection, and we just ended up going longer.